We chose that name because we needed a name. Probably the biggest mistake we ever made, because there was really, I mean, don't record that piece, but it's been 20 years, and we said we have to get away from this. We're bigger than that. And but my family's based on looks, very big. So my mother said, my father lost weight, he looks wonderful. I said, Ma, I kind of thought he looked good before. Just throwing that at her.
Well, he looked good to me.
Yeah, he looked good fat, we look good thin.
And there's a lot from it, I know it sounds really corny, but there's a lot from the inside that, for me, it registers. That's what registers to me. Like, how do you like make me feel, like, as we engage in conversation?
Right.
And that adds a lot to just how I deal with you as a person, because everything else, this.
Yeah.
To me, really, and like I said, I really know I sound cliche. It's really just skin deep. It's nothing.
Okay. Sometimes they do think it's a malpractice or mistakes, and it comes from the anger. Basically, comes from not knowing and not having that conversation. We live in a society that when things go wrong, the doors get closed on the patient and family, and over the years, in parts of the country, that's changing. There's programs called disclosure, and healthcare facilities and doctors are being trained in disclosure and how to talk to the family, and conflict resolution and mediation. There's these services out there for the patients and families. They're not happening nearly enough. They're not fast enough. And many people, studies have shown that when there is a disclosure and honesty and conversation with the family after a bad outcome, the family's not going to sue. A lawsuit usually comes from getting answers, and we have a right to know what happened. So many cases, if a patient and their family want to know what happened and they're not getting the answers, they're going to have to seek legal consult to get that information. Ideally, we don't, as an organization, myself, we don't make that judgment call. Our focus, we don't give medical advice, we don't give legal advice. We want to make sure the patient is heard, the patient and their family are at peace, that they're empowered to get the information that they want. And if doors get closed on them, we'll help open those doors to conversation, whatever that conversation might be and wherever it might go.
Great.
Is that helpful?
Oh, I love
Yes,
when something goes wrong, doors get closed.
Yes.
That was great.
Yes.
Yeah.
So I'm going to switch gears a little bit. What concerns do you have for African American women in healthcare?
The studies, there's studies that show that, you've heard the numbers, that African American women do not get the same care. They die earlier. And forgive me for not using the word mortality, because that's a word that not everybody understands. The death rate is what we're talking about. African American women die earlier because of conditions that we understand those studies. What my concern is, and what I think as an organization our concern is that these studies are being done, this research is being done, it's being put out there. What are we doing about it? And that happens in healthcare across the board. Patient safety, studies are being done. What are we doing about it? So our focus is really getting to the patient, telling them it's okay if you think that there is disparities in your care, that you feel that you're not being treated equally, because chances are it's true. And here's the studies. People who are sick, people who have been injured and in the healthcare system, aren't going to start looking at these studies. We have these studies at our fingertips. So if I get a call from somebody who says, I feel I'm not being treated fairly, I'm a black woman in this situation, I'm going to believe her because the studies show that this is a problem. I'm not going to automatically think that everybody else around her is wrong, but we have to acknowledge that these are the studies. As a white woman, I could be a really good ally and advocate for people who are of color, and be part of that transition into safer, better quality care. Chances are people who work in healthcare at the bedside, the immediate nurses, the bedside nurses, got into this profession to help people, to save lives, and they do it every day. But there are disparities, and if we recognize it, acknowledge it, and fix it, we'll save lives.
Great.
That was good.
Yeah,
Good answers.
that was good. Anyways, that was one other question. I had it on tip of my tongue until I start playing. You got anything?
I guess the future,
Yeah.
the future of Pulse, and you know, short-term goals, long-term goals.
We, if you want to talk about obstacles,
All of it.
okay.
Ups, get up, short term, long term,
Okay.
and obstacles.
So the short-term goal, what I see in the future for Pulse and what we hope to achieve in this work is to have across the country places where people can call to get advice, to get support, and get trained as an advocate. We do training. We train family members to be advocates. We want the country filled with people who will help other people as volunteers, as paid advocates. We're told constantly, don't go to the hospital alone. And if you're not going to go alone to the hospital, who are you going to bring? So I bring my best friend, and my best friend sits and knits and doesn't know that these are problems, doesn't know what to look for. We want that best friend trained to be an advocate and be able to speak up and be able to gently but respectfully and assertively ask a doctor to wash their hands because they're not doing it. And if they're still not doing it after 100 years of hand washing being proven as a reduction of infection, then we need another step in preventing hospital infections or problems in care. So we need to train family members and loved ones throughout the country on being an advocate and being part of the team to reduce disparities, reduce medical errors, reduce bad outcomes. Ideally, if we could do that short-term, long-term, that's our ultimate goal. A phone call from the bedside, which is really the most common of what we get, that somebody's not being listened to. Somebody doesn't know who's in charge of their care. They're being told different information. They're confused. They're being discharged too soon. They're not being discharged. There's a whole host of things that people are concerned about when they're in the hospital. And those phone calls could be the stop of a medical mistake, could be a bad outcome, if we could intervene and give advice on what somebody can do, who they should speak to. They don't realize that if you are angry at the nurse because the nurse is not taking enough care of you, well, she might be overwhelmed. To be able to make a phone call to administration and say there's a problem in room 242, you need to get in there because this is what's happening, we could stop problems from happening and really improve relationships, improve satisfaction. That's what they're looking for now in hospitals, improved satisfaction. Preparing people to go to the doctor, training in to go to the doctor and say, I haven't slept in 2 weeks, is probably not accurate. If you're sleeping only 2 hours a night or napping during the day, it's a very different diagnosis than saying, I haven't slept in 2 weeks, or my baby is crying all night. Being able to describe your symptoms, know your medications, taking more control instead of the days of, oh, my doctor will take care of it. They don't have the time. We need to be more active and more in control of our care. So those are the things that we're trying to accomplish. And we can't do this without leadership in healthcare, without the doctors, without the nurses' input, without the people who've done this research, without leadership in hospitals. They support our work because they know it has to be done. The problem is there's no money involved. The money from the federal funding, the grants are all going to the hospitals. And when it goes to the hospitals, they get a choice of where to distribute it. If the cancer associations, the heart associations, if the diabetes associations were able to put in for grants to teach their patients about patient safety, then we would be able to flood the country with information on patients, not just about eating right and exercise, because even somebody who's obese, somebody who is an alcoholic, somebody who doesn't exercise, has a right to safe, quality care, and not to blame the patient for their condition, for a medication mistake or for infection, or it needs to be spread throughout the country for every organization that works with the community needs to get funding to do patient safety education. The black community needs that funding to be able to educate African Americans about these studies, about if they, if there's a diagnosis that isn't being taken seriously, they need to get involved in their care and to start making phone calls if they're not getting the care needed.
Thank you so much.
All right, can I get,
So Pulse started, like you said, started in Colorado, and then okay, we'll skip that part there. But anyways, what's your relationship to Dr. Leslie Farrington? How did you all meet and start?
Leslie and I are part of the same congregation where we started meeting in the late 90s. She started coming, and we did the first Patient Safety Awareness Week we did at this congregation, and we did a health fair. And it was very awkward at first because she was a doctor, or she is a doctor, and I wanted to be very careful and very gentle in our relationship because I feared that doctors would think that we're against doctors, and we're not. And when she realized what we were about, she jumped right in and got very involved and helped with the health fair and does presentations now, goes out to the community, and is very passionate about patient safety because of what she's seen over the years. And she's taken this piece of it, very personal, and is really putting a lot of energy behind this. She's been our board chair. I don't want to date, but she's been very involved in educating the community. She does our advocacy training. We do that together. She speaks in every chance she gets about patient safety, and she's done videos, how-to videos we call them, and she really took it to her office and taught her patients about patient safety. So she does what she's the real thing, and she lives it. She lives it every day, and that's it's exciting for me to have that passion that I could work with her, and I'm sure I give her that same enthusiasm, and it's a good feeling. It's a good feeling knowing that she's that passionate about the work.
Okay. Thank you. That's great. That's it, Miss Eileen. I have definitely
Yeah.
gives you a whole new thing here, a whole new world.
Yeah,
to
so you
work
keep
with.
hearing Pulse of New York, and trying, we're really in the early process of changing
everything
over.
Yeah,
So we're not making like official thing, and
So
yeah.
here's another thing. How, and I know you spoke about